Good morning to everyone. Am I audible?
Yes, sir, you are audible, sir. Good morning, sir.
So, a very good morning and hope that you all are fine and still following the isolation and taking precautions for COVID 19. Okay, so today's topic is anti-malarial drugs. Okay, let me start with a story. While I was in internship, that was my first day of internship in medicine, and I was posted in OPD, okay, as an intern. A patient came to me. He was a 20 to 25-year-old male, and he was a sugarcane worker. You know, there is a sugarcane belt, right? Uh, he was from Jharkhand, and he was a migrant worker. The complaints that he told me was fatigue, and he had breathlessness, okay, and he was very pale. These were the only complaints, and our senior physician, he told me to take his history and admit him. Okay, so I took his history, and I admitted him in the ward, and some investigations they were prescribed, like the routine CBC and peripheral blood smear, etc. In the night, while I was in my quarters, I got a call from the same physician that the patient died. So I was very panicked. I went back to the ward, and there, when we saw the investigations, he was having malaria. Okay, and his hemoglobin levels were 2 gram%. Okay, so this is the start. This was the start of my internship, and I came to know that malaria is a very devastating disease. Okay, so generally this occurs as a complication of malaria if we do not treat the patient. Generally in falciparum malaria, because falciparum malaria, it can lead to complicated malaria and also many of the other complications. Okay, so treatment is very essential for patient of malaria. Otherwise, there will be anemia and the complications of malaria, and even the patient may die. Okay, so this malaria, do you know why malaria is known as malaria? Yes, malaria is known as malaria. It is derived from a Italian word, mal air. Okay, it also means bad air. So it is the Italian word for bad air. And around 4 to 5 popes in Italy, they had died because of this malaria. Okay, so it is a very devastating parasitic infection. In 2019, there were around 213 million cases. Okay, actually the number of cases they have reduced worldwide, and there were around 4 lakh deaths worldwide. Okay, and out of these 213 million cases, 93% of the cases, they are from WHO African region. Okay, and only 7% of the cases are from the rest of the world, in which in the rest 7%, India also comes with a load of around 3 to 4%. Okay, so in India, it was a very it was a very devastating disease, right? And that's why National Malaria Eradication Program was started in 1958. and the number of cases, they decreased drastically after this program was started, from 75 around 75 millions to less than 1 million. Okay, so this was achieved in 1960s, but later on the number of cases, they started increasing. Okay, why? Because the precautions and measures which were used, like they were spraying some insecticides to kill the mosquito. So the mosquitoes, they became resistant to the insecticides, and that is why uh, again there was resurgence of malaria in India. Later on, this program was named as National Anti-Malaria Program, and nowadays this program is known as National Vector-Borne Diseases Control Program. Okay, so this program includes all the vector-borne diseases now, like malaria, dengue, leishmania, etc. Okay, so what is the etiological agent of malaria? You all know that malaria is a parasitic disease which is caused by plasmodium, right? Plasmodium species which infect the humans. And these are mainly four plasmodium, that is Plasmodium vivax, Plasmodium ovale, Plasmodium falciparum, and Plasmodium malariae, right? There is also the fifth plasmodium, that is Plasmodium knowlesi. Okay, Plasmodium knowlesi, and this is mainly responsible for the zoonotic malaria. But nowadays, it is found very rarely in human beings also because of deforestation. Okay, so Plasmodium vivax, ovale, and falciparum, they are tertian malaria. What do you mean by tertian? That is the fever or episodes of fever, they occur every third day. Okay, every third day or every 48 hours. And cotton malaria, that is Plasmodium malariae, it is known as cotton because the fever occurs every fourth day. Okay, now vivax and ovale, they are responsible for benign tertian malaria. Benign because it is not so serious, right? Whereas falciparum malaria, it is also known as malignant tertian malaria because it is associated with complications. Okay, the RBCs, they form a Rolex in case of Plasmodium falciparum, which can clog the various arteries, and that can lead to the complications of falciparum malaria, like cerebral malaria, etc. And that is why it is also known as malignant tertian malaria. Okay, so in today's class, we will be discussing about first the life cycle of malarial parasite. Why? Because it is very important to know the life cycle of malarial parasite so that we know at which stage the anti-malarial drugs, they act. Okay, then we will see the classification of anti-malarial drugs, uh, which is of two types. One is the therapeutic or clinical classification, and second is the chemical classification. Then we will go to the anti-malarial drugs, mainly chloroquine and few others, their mechanism of action, uses, and adverse effects. Okay. So symptoms of malaria, you all know the symptoms of malaria. Malaria begins with chills and rigors associated with fever, right? Then there is a phase of sweating. Okay, there is also associated headache, muscular pain, back pain, and in chronic cases of malaria, there may be splenomegaly. Okay, the malaria can be described. The symptoms can be described mainly by the paroxysms of malaria. Like there are three stages: cold stage, hot stage, and sweating stage. So cold stage, there is feeling of intense cold and vigorous shivering. Okay, even if you put the blanket on the patient, still he will be shivering because of rigors. Then there is hot stage, in which there is a rise in fever, dry burning skin, and throbbing headache, which lasts for 2 to 6 hours. followed by profuse sweating. The temperature decreases and there is feeling of exhaustion. Okay. So what is the life cycle of malarial parasite? So the life cycle of malarial parasite, it can be discussed under two headings. One is the sexual phase, which occurs in the mosquito. Okay. The sexual phase, it occurs in the mosquito, and asexual phase, which occurs in the human beings. What is the definitive what is the definitive vector for malaria? What is the definitive host for malaria?
Plasmodium, no, our female Anopheles mosquito.
Yes, very good. The definitive host for malaria is the female Anopheles mosquito, right? Male Anopheles mosquito, it does not transmit the malaria, right? And human beings, they are the intermediate host. Okay. So the life cycle of malaria, it can be described in two phases. One is sexual and another is asexual. Asexual occurs in human beings. So it all begins with a bite of mosquito. When the female Anopheles mosquito bites an infected human being, and if there are gametocytes in his blood, those male and female gametocytes will be taken up by this mosquito, okay, sucked along with the blood. In the mosquito gut, okay, that is the gastrointestinal tract of the mosquito, the blood, it will be utilized by the mosquito, and there will be no destruction of these gametes. The male and female gametes, they will fuse and they will form a zygote, then it will form a oocyst, then a ookinete, and this ookinete, then it is converted to the sporozoites. Okay, so this sporozoites, they will then go and transfer to the salivary glands of the mosquito. Okay, so sporozoites, they are transferred to the salivary glands of the mosquito, and whenever this mosquito, right, it bites the human being, this infected mosquito will transfer these sporozoites to the human beings. Okay, and this is the beginning of asexual phase. This sporozoites, they cannot survive for a long time in the blood. Okay, within an hour or so they will be destroyed, and that is why they seek refuge in the liver. Okay, they will be taken up by the liver, and in the liver there will be formation of a primary schizont. Okay, there is formation of a primary schizont which is multinucleated. Okay, and this primary schizont, after 8 to 21 days of maturation, it will be converted to multinucleated merozoites. Okay, and these merozoites then will be released from the liver. Okay, the merozoites which are released from the liver, they attack the RBCs. They will be attached to the RBCs and they will be internalized in the RBC. In the RBC, these merozoites will undergo various stages. They will be converted to tropozoites. Okay, tropozoites, they are the intracellular parasites. There will be vacuolation. There will be formation of the ring form of tropozoites. So you can see all these various stages in the peripheral blood smear. Okay, so this tropozoites, they are formed in the RBC, and then these tropozoites are converted into the erythrocytic schizonts. Okay, and then this erythrocytic schizonts again are converted into the merozoites, and the RBC, it ruptures, because of this merozoite load, and these merozoites are released into the circulation. Okay. When the RBCs rupture, this coincides with the shivering. Okay, because when RBCs rupture, there is also release of the inflammatory mediators like tumor necrosis factor alpha, interleukin 1, 6, and uh, tumor necrosis factor gamma. So these inflammatory mediators, they are released, which lead to the shivering. Okay, so these merozoites, which are released again by the breaking of the RBCs, again they will attach to the other RBCs, and again this cycle will go on and go on. Okay, so this is known as erythrocytic schizogony phase. The phase in the liver is known as pre-erythrocytic phase. Okay, this is pre-erythrocytic phase. So the primary tissue schizones in the liver, they are converted to merozoites, right? But few of these primary tissue schizones will also go into the dormant stage in case of vivax and ovale. In case of plasmodium vivax and in case of plasmodium ovale, there will be formation of hypnozoids, okay, in the liver. So these hypnozoids, they will hide in the liver, and they are responsible for this dormant form. Okay, after weeks or months, they may be released from the liver, and then they will cause relapse of malaria. Okay, hypnozoids are not formed in falciparum malaria. Okay, malaria caused by falciparum, hypnozoites are not formed. This is also known as exoerythrocytic stage. Exoerythrocytic. What is exoerythrocytic stage? The stage of formation of hypnozoites. So first is pre-erythrocytic, then exoerythrocytic, then erythrocytic schizogony. Okay. Now some of the merozoites, they are converted to the gametes, male gametes and female gametes, and which will be taken up by the mosquito whenever the mosquito bites. Okay, so this is the life cycle of the malarial parasite. Okay, so if you want to prevent the attack of malaria, what are the options available with you? The first option is you destroy the sporozoites in the human body before they enter the liver. Okay, but that is not possible because there is no such drug which is a true causal prophylactic which will destroy the sporozoites. Okay, second thing is you can give a drug which acts on the pre-erythrocytic or exoerythrocytic stage. That is, you prevent the release of merozoites from the liver, or also you kill the hypnozoites. Okay, so that is known as causal prophylaxis. What is causal prophylaxis? Causal prophylaxis means killing of the hepatic forms of the malarial parasite so that it doesn't go to the erythrocytic schizogony stage. Okay, the third type of drugs, they are the suppressives. Okay, suppressives, they have action only on the erythrocytic schizogony stage. Okay, they will act on the various stages of the malarial parasite in erythrocytic schizogony. Okay, only on the erythrocytes. Okay, so they are known as suppressives. So suppressives can be used to terminate the clinical attack of malaria. And then we have gametocidal drugs. Gametocidal drugs will prevent the, what will the gametocidal drugs do? They will prevent the transmission of malarial parasite or transmission of malaria, right? So these are the various groups of drugs depending upon the life cycle of the malaria. Okay, true causal prophylactic, we don't have any drug. Causal prophylactics, we have drugs starting with P. Okay, that is primaquine, proguanil, and pyrimethamine. Suppressives, majority of the drugs, they are suppressives like mefloquine, quinine, all the drugs, they are the suppressives. Gametocidal, we have again primaquine, which is gametocidal against all. Then chloroquine is gametocidal only against Plasmodium vivax and OL, also quinine. And artemisinin group of drugs, they are gametocidal against the initial stages of the gametes. So that is the classification based on the life cycle. Okay, is it clear? So remember the life cycle of malarial parasite. You have pre-erythrocytic stage. Okay, in pre-erythrocytic stage, there is release of murozoites from liver. Okay, exoerythrocytic stage. What is exoerythrocytic? Formation of hypnozoites. Okay, some of the tissue schizones. Okay, some of the tissue schizones in the liver, they are converted to hypnozoites. And this exoerythrocytic stage, it is special only for vivax and oval. Okay, exoerythrocytic stage or hypnozoites, they are not there in Plasmodium falciparum, right? Then we have erythrocytic stage, erythrocytic schizogony. Okay, so relapse is common, or relapses of malaria, they can occur with vivax and oval malaria, right? Because of hypnozoites or the hidden or dormant form. And that is why for complete eradication of vivax and oval, we have to give radical cure. Okay, what is radical cure? Radical cure means complete eradication of the parasite from the human body. So for radical cure of vivax and oval, you have to give such a drug which is effective against hypnozoites. And that drug is primaquine. Okay, so primaquine is given for radical cure in cases of vivax and oval malaria for a period of 15 days. Okay, after the chloroquine or quinine, any drug which we give, after that, this primaquine is given for 15 days in case of vivax and oval, whereas in cases of falciparum malaria, only one dose, single dose of primaquine, 45 milligram is sufficient. Here we give 15 milligram for 15 days, but in case of falciparum malaria, only 45 milligram is given a single dose after the routine drugs which act against the RBC forms. Okay, this we are doing in falciparum malaria to kill the gametes. Okay, so did you understand what is radical cure? Radical cure means eradication of the all forms of parasite, and it is essential in cases of vivax and oval malaria because of presence of hypnozoites.
Sir,
Okay,
a small
now,
doubt, sir.
yes,
Sir, um, is there a special test to find out which type of organism attack? I mean, falciparum, oval, vivax. How do
yes.
we know?
So it is very simple to find out the whether it is falciparum malaria or vivax malaria. Just you need to do a peripheral blood smear depending upon the shape of the gametes. Okay, you can identify which parasite it is. Okay, one of them has a banana shape and another one has a ring form of the gametes. Also, depending upon the various stages, there are 40 or 41 differences in between falciparum and oval. Also, there are some quick tests also nowadays to differentiate between falciparum and oval malaria. So it is not so difficult. Okay.
Yes, sir. Thank you so much, sir.
Okay, objectives of anti-malarial treatment. The first objective is to prevent the clinical attack of malaria, that is prophylaxis. Okay, prevent the attack of malaria, and this can be done by either killing the sporozoites, which is not possible, or by killing the forms in the pre-erythrocytic stage. Okay, by using primaquine or proguanil or pyrimethamine. Second objective is to treat the clinical attack of malaria. Okay, that is clinical curative. So the clinical attack of malaria can be cured by using drugs which are suppressives, which act on the erythrocytic stage. Third objective is to completely eradicate the parasite from the patient's body, and this can be done by using the drugs which are effective against the erythrocytic schizogony as well as against hypnozoites or pre-erythrocytic stage. Okay, and the fourth objective is to cut down the human mosquito transmission, and this can be done by the gametocidal effect of the drugs. Now coming to the classification of anti-malarial drugs. Classification of anti-malarial drugs. There are many classifications mentioned in your books, like classification based on the stage of the life cycle which the drugs act. Then you have therapeutic classification and chemical classification. So therapeutic classification, you can classify the anti-malarial drugs into the causal prophylactics. Okay, what are causal prophylactics? Causal prophylactics are the drugs which act on the pre-erythrocytic stage. Okay, they are also known as tissue schizonticides. Okay, so they destroy the parasite in liver cells and prevent the invasion of erythrocytes. The best drug is primaquine. Primaquine is effective against pre-erythrocytic as well as it is effective against exoerythrocytic or hypnozoites. Proguanil and pyrimethamine. Okay, proguanil and pyrimethamine, they are only effective against the pre-erythrocytic stage. Okay, that is, they are not effective against the hypnozoites. Second group is suppressive prophylactics. Okay, suppressive prophylactics, they have the action on the merozoites, which are released from the liver. Okay, what do? They destroy the merozoites which are released from the liver, and they suppress the erythrocytic phase. Okay, and they can be used as prophylactics. So generally this chloroquine, proguanil, mefloquine and doxycycline, they are used for chemoprophylaxis. This is also known as chemoprophylaxis. This chemoprophylaxis is indicated in some special conditions. What are those special conditions? Like in a patient, in a person who is going to an endemic area. Okay, so he wants to prevent himself from malaria, like a European or some Western people. They are coming to, they are going to Africa or India. They will require prophylaxis. Okay, so for that purpose, you give chloroquine, or depending upon the sensitivity, like some areas, this chloroquine resistant malaria is there. So there you will give the other drugs like doxycycline or mefloquine. So we will see this in the next class, how you do the chemoprophylaxis. Just remember that this is suppressive prophylaxis. Clinical cure, it is used to terminate the episode of malarial fever. Okay, so these are the drugs which act on the erythrocytic schizogony. You have two types of drugs: fast acting drugs. They have high efficacy and they act very fast. That is, you can remember it by MACHAR, machar. M for mefloquine, A for atovaquone, C for chloroquine, H for halofantrine. Okay, H stands for halofantrine, and A for artemisinin, and R is for resoquin, that is quinine. Okay, the trade name of quinine, that is resoquin. Slow acting or low efficacy drugs, they are the others like proguanil, pyrimethamine, sulfonamides like sulfadoxin, also tetracyclines. Dapsone also has some effect, doxycycline. Okay, so these are the slow acting or low efficacy drugs. Radical curatives, we have already seen what is radical cure, and for Vivax, we are using primaquine as a radical cure, 15 milligram daily for 14 days. Okay, and gametocidal drugs, you have primaquine. Primaquine is effective against all plasmodia, very effective, right? Artemisinin is effective only against the early forms of the all plasmodia, that is Vivax, oval, malaria, and falciparum. Chloroquine and quinine, they are effective only against Vivax and oval. They are not effective against the other forms. And proguanil and pyrimethamine, they prevent the development of sporozoites. For you, just remember that primaquine is the best gametocidal drug. Okay, and it is given in falciparum malaria as a single dose, 45 milligram, after giving the artemisinin combination therapy, just to kill the gametocytes. Okay, so is it clear, the therapeutic classification? Now coming to the chemical classification of malaria. Okay, antimalarial drugs, most of them, they are the quinolines, 4 aminoquinolines, 8 aminoquinolines, quinoline, methanol. Okay, so these three groups, they are the quinolines. So 4 aminoquinoline group of drugs, chloroquine, then sister of chloroquine, that is hydroxychloroquine. Then you have chloroquine like drug, amodiaquine, and also you have this pyronaridine. Pyronaridine, it is a drug used in China, which is also a 4 aminoquinoline. Also piperaquine is the another drug. 8 aminoquinolines, remember primaquine. Okay, primaquine is a 8 aminoquinoline. And what is the use of primaquine? One is for radical cure, second is as a gametocide, right? Uh, Disadvantage of primaquine is primaquine needs to be given every day. Okay, so they have synthesized these two drugs, tafenoquine and bulaquine, which can be given, which are having long duration of action and long half-life, and they can be given on weekly basis. Okay, so they are just like primaquine, tafenoquine, and bulaquine. Now, just like the other antibiotics or antimicrobials for any infective disease, the resistance is also a problem in malaria nowadays. Okay, in India, previously Vivax was more common, but now it is 50-50. That is, falciparum also is present in about 50% of the patients. Okay, so chloroquine resistant malaria is a major problem. Okay, and that is why you need to know about the drugs which are used in chloroquine resistant malaria. Okay, so in chloroquine resistant malaria, you can use all other drugs apart from chloroquine, which are effective against the erythrocytes, like mefloquine, quinine, and sulfadoxine pyrimethamine combination. And best is the artemisinin group of drugs. Okay, this sesquiterpene lactones, they are also known as artemisinin group of drugs. So they are the fastest, quickest acting drugs and very effective for treatment of falciparum malaria. Okay, then you have alkaloids, cinchona alkaloids, that is quinine and quinidine. Okay, you know the history of antimalarial drugs. In previous days, old days, for fever, they used to use bark of
Then
bark of
Canine, canine plant.
tree, that is the cinchona bark, which is an alkaloid. Okay, quinine. Also in China, they used to use the wormwood tree uh, they used to use for malaria, right? So this quinine is obtained from the cinchona bark. It is a cinchona alkaloid, right? Proguanil, it is a bigonide. Which is the other bigonide, you know? Any other bigonide you know which is used in therapeutics? Remember anti-diabetic drugs? Metformin, right? So proguanil is a bigonide. Then you have antimicrobial drugs. These three groups are of antimicrobial drugs like pyrimethamine, sulfadoxine, dapsone, tetracycline, and doxycycline. You can remember it as antimicrobial drugs. Then you have atovaquone, and last group is artemisinin group of drugs. Okay, sesquiterpene, lactone is their chemical structure, and they are artesunate, artemether, arteether, and also dihydroartemisinin and arterolone. So this group of drugs, that is artesunate, artemether, and arteether, they are not used alone. They are also they are always used in combination. That is known as artemisinin based combination therapy, because they are fast acting, and to prevent the resistance, they should be used in combination with slow acting drugs. Like they are used, artemisinin or artesunate is used along with sulfadoxine pyrimethamine, or artesunate is used along with mefloquine and along with some other drugs, which we'll see in the next class. So they are the fastest acting drugs. Okay. What are the fast acting drugs? Machar, Machar, right? But among them, the fastest is artemisinin group of drugs, right? Then you have chloroquine and quinine, which are equally fast. Okay, chloroquine and quinine. Then you have others like atovaquone and others, mefloquine. Okay, so this is how you remember the chemical classification of anti-malarial drugs. Remember that the first group is of quinolines, that is 4 amino quinolines, 8 amino quinolines, quinoline, methanol. Okay, 4 amino quinoline, remember chloroquine. 8 amino quinoline, remember primaquine. Quinoline methanol, remember mefloquine, right? Then you have alkaloid, which is obtained from cinchona bark, that is quinine. Okay, quinidine is not used as an anti-malarial drug. It is used as an antiarrhythmic. Remember, class 1 antiarrhythmic, class 1A, right? That is quinidine. So, quinine also has the cardiac depressant action. Okay, and it is also cardiotoxic, but less than quinidine. So, quinine is used in treatment of malaria. Previously, it was the treatment of choice for falciparum malaria, but now artemisinin group of drugs, they are the treatment of choice for resistant chloroquine resistant malaria, that is plasmodium chloroquine resistant plasmodium falciparum malaria. Okay, then you have antimicrobials, and then you have artemisinin group of drugs. The classification of anti-malarial drugs is very important. Okay, uh, whenever you are asked the classification of anti-malarial drugs and it is not mentioned which classification, write the chemical classification. Okay, you can also write the therapeutic classification. Okay, if you remember. Okay, so classification, any query or doubt in classification? So now coming to the individual drug, chloroquine. Okay, so this chloroquine was synthesized by in USA. Okay, first it was synthesized in USA, and at the same time it was also synthesized by the Germans under the name of Resocin. Okay, uh, The first anti-malarial drug which was synthesized was in 1820. It was quinine. Okay, so quinine was used for a long time, and this anti-malarials, they have a long history, and they were very useful in the World War One and World War Two. Okay, so in these world wars, what did the alliance countries do? They stopped the supply of the quinine which was produced in Java. Okay, Java, you know, it is a country. It was the major producer of this quinine, and they stopped the supply of this quinine to Germany. So a lot of research was done into these antimalarials by Germany and also by the other countries, and they came up with the first drug after quinine, that is mepacrine. But mepacrine was very toxic, and then the Germans, they researched further, and they came up with this drug, that is chloroquine. So chloroquine was synthesized simultaneously in Germany as well as in US. So this is the structure of chloroquine. At position 7, there is chloride, and this chloride this chlorine is very important for its anti-malarial action. Okay, so it is a 4 amino quinoline. Why 4? Because at the fourth position it has amino group 4 amino, and this 2 benzene rings with a nitrogen here is known as quinoline. So chloroquine has 2 forms or 2 isomers, D chloroquine and L chloroquine. D isomer is less toxic and it is therapeutically used. Now the antimalarial action of chloroquine. Chloroquine is very effective against the erythrocytic forms, erythrocytic schizogony of vivax and oval, vivax, oval, and malaria, but it is less effective against falciparum. Okay, and also you have to see whether it is sensitive, depending upon the area, whether the area is resistant to chloroquine or falciparum. The WHO and also the National Vector-Borne Disease Control Program, it has labeled the areas as chloroquine resistant and chloroquine sensitive. So depending upon that, you modify your treatment. Okay. So the first choice is chloroquine if the malaria is chloroquine sensitive. If it is chloroquine resistant, then you go for whether it is uncomplicated or complicated. Based upon that, you modify your therapy. Chloroquine, it has no activity against tissue schizones. Okay, so it is not effective against pre-erythrocytic stage. It is also not effective against the hypnozoids. It is only effective against the erythrocytic stage. So by definition, it is a by definition it can be used in as a suppressive for chemoprophylaxis, or it can be used for the cure of malaria. Okay. Now, what is the mechanism of action of chloroquine? Chloroquine is a basic drug. Okay, chloroquine, it is a basic drug, and it gets concentrated in the acidic, okay, it is concentrated in the acidic vacuoles of malarial parasite. Okay, so this malarial parasite, it requires hemoglobin for its nutrition, right? When it sucks blood, this hemoglobin, it is utilized for the nutrition of the malarial parasite. It is broken down into heme, which is highly toxic for the malarial parasite, and the globin part for its peptides, which are converted to the amino acids and utilized by the malarial parasite. So chloroquine can inhibit this step, that is the formation of peptides from the globin, as well as it can inhibit one enzyme, that is heme polymerase. Okay, so this heme which is formed by the malarial parasite has a mechanism to convert this toxic heme to non-toxic hemozoin. Okay, so malarial parasite, it has an inbuilt mechanism which converts this toxic heme to non-toxic hemozoin with the help of enzyme heme polymerase, right? Why it requires this mechanism? Because heme is highly toxic for the malarial parasite. This heme can destroy the plasmodial membranes, okay, and it can kill the malarial parasite. So we are using this mechanism against the malarial parasite only. Chloroquine, quinine, and mefloquine, they share the mechanism of action. What is their mechanism of action? First is they inhibit the peptide formation, decrease the nutrition for the malarial parasite, and second is they inhibit the heme polymerase enzyme. Okay, they inhibit the heme polymerase enzyme, and they will not they will inhibit the formation of hemozoin, which is non-toxic. And the heme chloroquine complex, it is toxic to the malarial parasite, and it will lead to the destruction of the plasmodial membranes and kill the malarial parasites. Okay, so this is the mechanism of action of chloroquine, mefloquine, as well as quinine. So chloroquine is basic. It gets concentrated in the RBCs. In the RBCs also, it is more concentrated in the parasite vacuoles, which are acidic, and it can get trapped in the food vacuoles, and it inhibits the conversion of heme to hemozoin by inhibiting the heme polymerase enzyme. Okay. Now, uh, there is a problem of resistance with chloroquine, which is very important. So why this resistance occurs to chloroquine? So chloroquine resistance, it is slow to vivax and oval, but it is very fast in cases of Plasmodium falciparum. So it is mainly because of mutation in the Plasmodium falciparum chloroquine resistant gene, PFCRT gene. So this gene is responsible for majority of the cases, of resistance of Plasmodium falciparum to chloroquine, PFCRT gene. So because of this mutation, the chloroquine will be thrown out of the Plasmodium uh, vacuoles, and there will be falciparum resistance. Then PFMDR gene, that is Plasmodium falciparum multi-drug resistant gene. This gene is less important in cases of chloroquine, but still it can occur, and it is mainly responsible for the resistance to antimalarials like quinine and mefloquine. It is related to P glycoprotein, and again, this antimalarials, they will be thrown out of the plasmodium. So this is the mechanism of resistance. Now, what are the other actions of chloroquine? The first and foremost use of chloroquine is in malaria. Which malaria? Plasmodium vivax and oval malaria, or malaria which is sensitive to chloroquine. Okay. Second use is as an antimalarial in chemoprophylaxis, right? But also chloroquine has some other actions. What are those other actions? It is effective against giardia. Okay. It is also effective against teniasis and extraintestinal amoebiasis. It is okay. So it is more concentrated in the liver, and it kills the tropozoid forms of the amoeba, and it can be used in hepatic amoebiasis as a reserve drug. The drug of choice still is metronidazole, right? The treatment of choice for extraintestinal amoebiasis is the nitroimidazoles like metronidazole, but chloroquine is also effective. Chloroquine is absorbed Majority of it is absorbed from the upper intestine, so it will not be so much effective in the colon. Also, it is a cardiac depressant, so this you should keep in mind when you are giving chloroquine intravenously. Okay, so the cardiac depressant effect can occur, and it is not given along with other cardiac depressant drugs. Like you should at least keep a gap of 12 hours when you are giving mefloquine or other cardiac depressants along with chloroquine. So it has a cardiac depressant action. It has a smooth muscle relaxant action. It is also a vascular smooth muscle relaxant, but not used therapeutically for this purpose. It is having anti-inflammatory action. So because of this anti-inflammatory action, chloroquine is used in the treatment of rheumatoid arthritis. Okay, chloroquine is a DMARD, disease modifying anti-rheumatic drug, and it can be used in mild cases of rheumatoid arthritis. It is used in lepra reaction. Which lepra reaction? Type 2.
Leprosy type 2,
Type 2. Type 2 is
lepromatous.
ENL, erythema nodosum leprosum, right? And also it can be used for the other diseases like infectious mononucleosis, etc. It is having antihistaminic and local anesthetic action also, but not used for this purpose. Okay, so these are the other actions of chloroquine. Important pharmacokinetics of chloroquine. Chloroquine can be given by oral route. It can be given by intramuscular route. It can be given by IV route. But you have to be careful when you are giving by IM and IV route. Especially IV route, you have to give it slowly because of the cardiac depressant action. Orally, it is well absorbed. It is more concentrated in the RBCs, liver, spleen, kidney, and it has a tendency of sequestration in the body. Okay, that is cumulative effect may be seen. Cumulative effect is because of its long half-life and also because of its plasma protein binding, and it can also bind to the chromatin in the body. So it is actually uh, very well distributed to the various parts of the body, and selective accumulation, especially in the retina. So that can lead to retinopathy. Okay, a serious adverse effect, that is retinopathy, in which there will be loss of vision or visual field defects. Visual field defects can be there. So ocular toxicity can occur when chloroquine is used for a long period of time. Half-life is 3 to 10 days, and it goes on increasing because of its cumulative effect. Okay, because it gets accumulated in the body, it may increase from few days to weeks, and also the terminal half-life may be in months. So because of this, when it is used for long term, you can see long term adverse effects of chloroquine. Now, what are the adverse effects of chloroquine? Normally, when you use it for malaria, you use it for a period of 3 days. Okay, so it is very well tolerated. You will just see some nausea, vomiting, anorexia, or allergic reactions. Okay, uh, otherwise, when it is used for long term, in which condition it is used for long term? In cases of rheumatoid arthritis. Okay, you use it for months together, right? It is a slow acting in rheumatoid arthritis. Its effect is seen after 3 to 6 months after the treatment, and you use it for a long period of time. So the long term adverse effects, first is retinopathy. Okay, why there is retinopathy? Because of the deposition in the retina, and it causes retinal vasoconstriction. Okay, retinal vasoconstriction is there, and it will lead to this retinopathy, which is also known as bull's eye maculopathy. Okay, so this retinopathy is seen in chloroquine toxicity. There may be CNS manifestations like ototoxicity, loss of hearing, mental disturbances, myopathy, graying of hair. This graying of hair is because of bleaching of the hair. Okay, so it is also a long-term effect. IV use may lead to hypotension and T wave abnormalities because of its cardiac depressant action. Okay, so these are the adverse effects. Normally, very simple adverse effects: nausea, vomiting, anorexia, skin rashes, uh, and on long-term use, retinopathy, hearing loss, mental disturbances, CNS adverse effects, and graying of hair. So dosage of chloroquine, it is used in the dose of 600 milligram base stat. Okay, base is important because this 250 milligram of chloroquine phosphate. Okay, chloroquine phosphate, it has 150 milligram of base. So this 150 milligram, or we consider the drug in base form or original form, right? So 150 milligram base tablet is available. One tablet of chloroquine is 150 milligram of base. So initially you give 4 tablets stat. Why you give 4 tablets stat? Because it is a drug having high volume of distribution. You want the target concentration in the blood. Okay, that is why you give in a loading dose. This is a loading dose. Loading dose is 4 tablets of 150 milligram stat.
Loading dose.
Then after 8 hours, you give 2 tablets, right? And then you give 1 tablet BD for 2 days. Okay, so this treatment along of chloroquine, it should be accompanied by primaquine, right? So we give tablet primaquine 15 milligram for 14 days in patients of Vivax and Ovel to achieve complete radical cure. Okay, to destroy the hypnozoids. So chloroquine should be followed by primaquine. In case of falciparum, just a single dose of 45 milligram. Okay, so this will achieve the radical cure in cases of sensitive forms to chloroquine. So I think this is sufficient for today, right? The important things that we have discussed today, first was the classification of the anti-malarial drugs. You classify them therapeutically, that is causal prophylaxis, right? Causal prophylaxis is mainly against the tissue schizones. Primaquine, best drug for causal prophylaxis. Second group is the suppressive prophylaxis, which kills the merozoites when they are released from the liver before they attack the RBCs, right? For that purpose, you can use chloroquine and mefloquine. Also, you can use doxycycline, right? The third group of drugs are used for clinical attack of malaria, known as suppressives, or drugs used for clinical cure, fast acting and slow acting. And then you have gametocidal drugs. Okay. Also for radical cure, you give combination of drugs effective against erythrocytic stage and pre-erythrocytic stage. Chemical classification of antimalarial drugs. Quinolines. Remember 3 types of quinolines: 4-aminoquinoline, that is chloroquine; 8-aminoquinoline, that is primaquine; and quinoline methanol, that is mefloquine. Then you have biguanide, that is proguanil. Then you have the antimicrobial drugs like sulfadoxine, pyrimethamine, right? Tetracycline, doxycycline. Also, you have few other drugs like atovaquone and artemisinin group of drugs, that is arteether, artemether, artesunate. So that is the chemical classification of antimalarial drugs. Chloroquine. Chloroquine is effective only against the erythrocytic stage, right? It is not effective against the pre-erythrocytic stage, and it is also effective against the gametes of Vivax and Ovel. It has no tissue schizontecide activity. Mechanism of action inhibits heme polymerase and also inhibits the peptide formation and the nutrition supply to the malarial parasite. Uses of chloroquine. These are the uses of chloroquine, right? It is used in malaria, rheumatoid arthritis, extraintestinal amoebiasis, discoid lupus erythematosus. You can remember it by a mnemonic, my red lip, right? M for malaria, R for rheumatoid arthritis, E for extraintestinal amoebiasis, D for discoid lupus erythematosus, L for lepra reaction, I for infectious mononucleosis, and P for photogenic reactions. Okay, also it is useful for giardiasis and clonosis sinensis, which is liver fluke. Okay, so these are the uses of chloroquine. One short note is asked for 2 marks in your exams. Why chloroquine is administered in loading dose in malaria? So chloroquine is very well absorbed and it is extensively tissue bound and sequestrated in the tissues like liver, spleen, kidney, and it has got a large apparent volume of distribution. That is why you need to give chloroquine in a loading dose. Initial 4 tablets or 600 milligram base we are giving as loading dose because of this purpose. Okay, any queries or doubts? So in the next class, we will discuss with the other anti-malarial drugs and the management of malaria. Okay, thank you very much.
Sir, for chemical regimen, why do we use sulfur drugs, sulfodoxin and dapsone?
We will discuss it in the next class. They are slow acting drugs, okay? They are used along with the fast acting drugs like artemisinin group of drugs, okay? Artesunate, it is given for 3 days. And then we are giving this sulfadoxine pyrimethamine along with it to prevent the resistance, okay? The life cycle, we should give the antimalarial drug for at least 5 to 6 life cycles of the malarial parasite. And if we have to give artemisinin or artesunate group of drugs for that purpose, you have to give it for a period of 10 days. Okay, in those 10 days, there is a chance of resistance. So to prevent that resistance, we are giving slow acting drugs. Initial artesunate will kill 95% of the malarial parasite, right? And then the remaining 5% can be taken care of by sulfadoxine pyrimethamine. So this is a very good combination, also approved by the WHO. Sulfadoxine pyrimethamine single dose along with artesunate. We will see this in next class. Okay.
Yes, sir. Thank you so much, sir.
Thank you very much.